My name is Dr. William Davis, and today our topic is She thought her triplets were perfect. Then this happened. She passed every ultrasound with flying colors. Her OB smiled at every appointment. She bought 3 matching cribs, 3 sets of tiny onesies, and told her family everything was going perfectly. And then, at 24 weeks, everything changed. In a single ultrasound visit, her world collapsed. And here's the most haunting part. The warning signs had been there for weeks. She just didn't know what to look for, and neither did most of the people around her. Today we're going to talk about something that affects thousands of American families every single year, yet almost nobody prepares for it. The hidden and life-threatening complications of multifetal pregnancies, specifically triplets and higher-order multiples. If you or someone you love is pregnant with multiples, or you're planning a family using IVF or fertility treatments, you need to watch this video to the end because what I'm about to share could save a life. Let me give you some numbers first, because the scale of this issue is bigger than most people realize. According to the CDC, the rate of triplet and higher-order multiple births in the United States, while lower than its peak in the late 1990s, still accounts for tens of thousands of high-risk pregnancies annually. The National Institutes of Health reports that women pregnant with triplets face a dramatically elevated risk of preterm birth, with more than 90% of triplet pregnancies delivering before 37 weeks. More importantly, the infant mortality rate for triplets is nearly 10 times higher than that for singletons. 10 times. That is not a small statistical footnote. That is a maternal and neonatal health crisis that lives quietly in the background of our healthcare system. So what actually happens inside a triplet pregnancy? Why is it so different from carrying one baby, or even twins? Think of your uterus like an apartment designed for one occupant. It can stretch, adapt, and sometimes comfortably host 2. But 3, that's where things get physically and biologically strained in ways that the body was simply not built to manage without significant medical support. When triplets share the uterine environment, they are competing, sometimes fiercely, for space, blood flow, and placental resources. In pregnancies where 2 or more babies share a single placenta, a condition called a monochorionic pregnancy, the risks escalate sharply. This is where 2 of the most dangerous and most under-discussed complications enter the picture. The first is twin-to-twin transfusion syndrome, commonly called TTTS. Even though the name says twin, this condition can occur in any pregnancy where 2 fetuses share a single placenta, including in triplet sets. What happens is this. The shared placenta develops abnormal blood vessel connections. Through those connections, blood begins to move unevenly. One baby, called the donor twin, pumps blood through the shared vessels and doesn't receive enough back. The other, the recipient, receives too much. Think of it like a pump and a reservoir connected by a leaky pipe. The donor shrinks and becomes anemic. The recipient becomes overloaded, overstressed, and at risk for heart failure. Without intervention, TTTS carries a fetal mortality rate of up to 90% in its severe forms. Let that number settle for a moment. The second condition is selective intrauterine growth restriction, abbreviated SIUGR. This occurs when one baby in a shared placenta set receives a disproportionately smaller share of placental territory. One fetus may grow normally, while another is essentially starved of nutrition and oxygen. The danger is that the smaller fetus can deteriorate silently. On a standard measurement ultrasound, the larger baby may look healthy, and the overall pregnancy may appear reassuring until a specialist looks deeper. But here's what most people get completely wrong. They assume that because multiple ultrasounds have been normal, the pregnancy is safe. That's not how these conditions work. TTTS and SIUGR can develop rapidly, sometimes within days, in the second trimester, and the routine OB ultrasound used to confirm dates and basic anatomy is not the same as the specialized surveillance ultrasound needed to catch these changes in real time. So what are the warning signs that something is going wrong? And I want to be clear, many of these signs are subtle, and some are entirely silent in the early stages. But for the mother, there are things to watch for. Sudden, rapid abdominal growth in a short period of time, like noticeably outpacing your previous week's measurements, can indicate polyhydramnios, a dangerous accumulation of amniotic fluid in the recipient twin sac. Shortness of breath that feels disproportionate to your current week of pregnancy. Unusual tightness or pressure in the lower abdomen. Decreased fetal movement, particularly in one area of the belly where one baby has been consistently active, and one that almost every patient tells me they dismissed. A persistent, dull sense that something just doesn't feel right. Have you ever heard a pregnant woman say that and been told it was anxiety? That dismissal has cost lives. For the babies themselves, the warning signs show up on ultrasound as discordant fluid levels. One baby swimming in too much fluid, the other with too little. Abnormal Doppler flow in the umbilical cord, a size difference between babies that grows week over week. And bladder findings, the donor baby may have a barely visible bladder while the recipient's bladder is chronically distended. If these conditions are not caught early, the consequences escalate quickly. In TTTS, both babies can die. In SIUGR, the smaller baby can experience sudden cardiovascular collapse. And because the babies share circulatory connections, the death of one fetus can send a catastrophic hemodynamic shock through those shared vessels to the surviving baby, causing stroke, brain injury, or death in the sibling within minutes. This is why timing and surveillance frequency are everything in high-risk multiple pregnancies. So what should actually happen? What does appropriate care look like? If you are pregnant with triplets or any higher-order multiples involving a shared placenta, you should be receiving care from a maternal fetal medicine specialist, also called a perinatologist, not only a general OB. This is non-negotiable from a clinical standpoint. The American College of Obstetricians and Gynecologists recommends that monochorionic multiple pregnancies receive ultrasound surveillance every 2 weeks, starting at 16 weeks. Every 2 weeks, not monthly, not every 6 weeks, every 2 weeks. If your provider isn't doing this, that is a conversation you need to have today. For TTTS specifically, the most effective treatment, when caught in the right window, is a procedure called fetoscopic laser photocoagulation, or laser surgery. A specialized maternal fetal medicine surgeon uses a thin scope introduced into the uterus to precisely coagulate or seal off the abnormal blood vessel connections on the shared placenta. When performed at a specialized center between 16 and 26 weeks of gestation, survival rates for at least one twin improve to roughly 80–90%. That's the power of early detection and appropriate intervention. For SIUGR, management may include intensified monitoring, early delivery planning, or in severe cases, selective reduction procedures. Decisions that are heartbreaking, but that can be the difference between losing one baby or losing all of them. These decisions should only be made by a specialized team at a high-volume center. But here's what most people get completely wrong about multifetal pregnancies, and this is critically important. The assumption that fertility-assisted pregnancies are monitored enough because of how they started. IVF pregnancies receive intensive early monitoring, hormone levels, first trimester ultrasounds, and then are often transitioned back to a standard OB around 10 to 12 weeks. That transition, if it doesn't include a specific documented plan for high-risk surveillance, is where the gap opens. The critical surveillance window for TTTS and SIUGR typically begins at 16 weeks. If no one is actively watching at that frequency, during that window, these conditions can advance from stage 1 to stage 4, the most severe, before anyone sounds an alarm. Let's talk about some common myths because they're dangerous in this context. Myth number 1. If the babies have separate sacs, we're safe. Separate amniotic sacs, called dichorionic triamniotic pregnancies, do reduce the risk of TTTS significantly, but they do not eliminate the risk of other complications like preterm labor, preeclampsia, placental insufficiency, or cord accidents. Separate sacs does not mean low risk. Myth number 2. Everything looks fine on the growth scan, so we have time before the next appointment. Growth scans measure size, not real-time placental function or fluid dynamics. A baby who measures on track at one appointment can develop life-threatening cord Doppler abnormalities before the next scheduled visit. This is why Doppler ultrasounds and fluid assessments must be part of every surveillance appointment in monochorionic multiples, not just growth measurements. Myth number 3. This is so rare, it probably won't happen to me. TTTS occurs in approximately 10 to 15% of monochorionic twin pregnancies. With triplets that include a monochorionic pair, that risk is carried into a pregnancy that's already categorically high risk. This is not a rare edge case scenario. It is a predictable, identifiable, treatable complication that kills babies when it's not looked for. So what can a mother carrying multiples do right now, today? Ask your provider directly. Is my placentation monochorionic or dichorionic? If you don't know the answer to that question, find out before your next appointment. Ask whether you are being seen by or co-managed with a maternal fetal medicine specialist. Ask specifically whether your ultrasounds include amniotic fluid level assessment and umbilical Doppler studies, not just growth measurements. If you're already receiving bi-weekly surveillance, good, keep it. Don't skip appointments because you feel fine. In these pregnancies, feeling fine is not the same as being fine. Keep a daily kick count log. While this tool has limitations in triplet pregnancies due to the difficulty of attributing movement to specific babies, any sustained notable change in overall fetal activity deserves same-day evaluation. Do not wait for your next scheduled appointment. Call your provider. Understand where the nearest fetal surgery center is. In the U.S., there are approximately 20 centers that perform fetoscopic laser surgery for TTTS. If you are in a rural area or a region with limited access to specialized maternal fetal medicine, know in advance where you would go and what your transfer protocol would be. Your provider should have this plan on paper before 16 weeks. And finally, advocate loudly for yourself or for the pregnant person in your life. The story I described at the beginning of this video, the mother who reached 24 weeks with warning signs that weren't caught, is not a story of medical failure alone. It's a story of a system that still underestimates the urgency of high-risk multifetal pregnancies in too many community settings. You are allowed to ask hard questions. You are allowed to request second opinions. You are allowed to say, I want to be seen by a perinatologist. That advocacy may be the most important thing you do. The 3 most important things to take with you today. 1. All multiple pregnancies are not equal. Shared placenta pregnancies require specialized high-frequency surveillance beginning at 16 weeks. 2. TTTS and SIUGR can develop rapidly and silently, but they are detectable and treatable when caught in time. 3. The standard of care exists. The treatments exist. The surgical expertise exists. The variable is access and awareness, and now you have both. If someone you know is pregnant with multiples right now, share this video with them. One view could change the outcome of a pregnancy. 3 lives are depending on it. This content is for educational purposes only and is not a substitute for professional medical advice. Always consult a qualified healthcare provider regarding your specific medical situation.